Thank you everyone for joining us for the webinar on the theme treatment of ALK positive and BRAF positive melanoma. It gives me great pleasure to introduce our first speaker, who's none other than Dr. Ashish Singh, medical oncologist and also the head of department of medical oncology at Christian Medical College, Vellore. Without wasting any further time, I would hand over the mic to our eminent speaker. Over to you, sir.
Hi, good evening, friends. Thank you for joining on a weekday. And as you know, in the next an hour or so, we will discuss treatment of two diseases, both driver mutation positive. One of them is melanoma, and the other one is ALK positive lung cancer. And so, my job is to take you through treatment of melanoma and the driver mutation. What we all know is that we commonly encounter in melanoma is the BRAF mutation, and and you also know that the other therapy which has really made an impact in this disease is immunotherapy. And very often now all these agents are available in India, and then we in our clinic we try to help our patients with this deadly disease using these options. Now, in order for us to understand what is the best options, should it be chemotherapy, should it be BRAF inhibition, should it be immunotherapy, we need to kind of have a deep dive into these data, and we need to understand them. And then with that, we'll be more informed to talk to our patients about what these drugs bring to the table. So we will basically focus on the BRAF mutated melanoma, but I will have some slides on cross comparison with immunotherapy and how we make that decision. Uh, so that's the outline of my talk. And so we all know that just almost just not so long ago, just a decade ago, when we had nothing but chemotherapy in this deadly disease, most of our patients had a very dismal outcome. Only a handful of them responded to chemotherapy with a short progression-free survival, and invariably, most of them would progress within a span of 1 year. This curve here shows that if you see the landmark analysis at 1 year, the blue curve is the chemotherapy curve. Now, this has changed in the recent past with the advent of immunotherapy, which we know melanoma is a disease where the responses are high, the tumor mutation burden is high. However, also it was known for a long time that BRAF is a driver. However, we did not have good drugs to inhibit this. And initially, the story began with the first drug was Vemurafenib, and people were excited when they saw very fantastic responses, and single agent BRAF inhibitor were uh, used in this disease. So look at the green curve, that is the single agent BRAF inhibitor. What you see there is, in spite of achieving good responses, the responses did not last very long, and most of these patients did progress in short time, and finally there was resistance. So this was overcome by addition of MEK inhibitors. Now we know MEK is a downstream signaling uh, uh, part. I mean, MEK plays an important role in the RAF signaling, and MEK comes downstream. And what used to happen was, when you used to inhibit BRAF, the MEK used to kind of take over. And then we realized that when we inhibit both of these together, the responses were the best. And when I say best, that means it is as good as and as comparable to what you saw with immunotherapy. So today, as of today, if you look at the approved agents in treatment of this disease in the first line, you see this is the NCCN guidelines, which would say category 1 recommendations for immunotherapy as single agent, or as combo, like with the CTLA4 Nivo EP, or if you have a BRAF mutation, even use of these tyrosine kinase inhibitor, the combos, the both MEK and BRAF inhibitors, is a category 1 recommendation. And this is based on multiple studies, which some of them we'll discuss today. Now, also, before we start, I just want to highlight that most of these trials, when they enroll patients with melanoma, we are talking about predominantly the acral lentiginous or the cutaneous melanoma. We are not talking about the mucosal melanomas or even the GI melanomas, which sometimes we commonly see, especially because our population being dark skinned, our cutaneous melanomas are not as common as what we see in some of these in Australia or some of these European countries. So just a disclaimer that most patients who go into these trials do not have mucosal melanomas. They have the acral lentiginous type. Now, even though we are talking about great improvements with immunotherapy, but we all have known that and we have now some good experience of these agents, and we found that patients who actually respond and really benefit are actually only a handful. So much so that we talk about the tail of the curve, and we say immunotherapy PFS is not important; it's the OS. And who drives those OS? It's these 30 to 40% of patients in these trials who are actually responsible, and many of the patients actually do not benefit and progress very rapidly on these drugs. Now, BRAF inhibition is different from immunotherapy because this is specific, right? You're particularly blocking the driver mutation, and therefore, unlike immunotherapy where it seems to work in both in the presence of mutation or without, these agents are not expected to work without a known BRAF mutation. And the common mutations which was enrolled in these trials is BRAF V600-E mutation. Now, as developments have happened, different companies have developed their own molecules. Okay, in India, Novartis has we have Dabrafenib and Trametinib, both belongs to Novartis. However, we also have other molecules like Bemurafenib and Cobimetinib, or Encorafenib and Binimetinib, both made by some other companies. And across the trials, as you can see on the screen, we have seen that the benefit is consistent as long as you're blocking both BRAF and MEK together. So now, is it is BRAF mutated disease a bad disease, or is it that these patients do very particularly poorly? Actually, it's not so much so. So if you see here, these are just trials of immunotherapy trials, which where you're comparing different groups, one with BRAF mutation, one without BRAF mutation, and you see patients with mutation seems to have had better survival as compared to somebody who did not have this mutation. Now, was it due to access to these TKIs? Was it due to different biology? We really don't know. But having said that, in today's era, having a mutation is actually not a bad news, and those patients can do well. Now, for all of us who treat melanoma, we know this is a very heterogeneous disease. Well, by heterogeneous, I mean that there are some patients who just present you with only nodal disease, in a good performance status. They're young, they're fit. On the other hand, sometimes we have patients with a very short history of illness, but disease is widespread, metastatic to lung, liver, bone, brain. And those patients have a rapidly progressing disease, large tumor burden, high LDH levels. And so sometimes this is a disease which had happened in older people, so performance status. So a lot of patient-related factors do come into play. And when we have to make a decision in the clinic, we have to encounter for all these factors in deciding how do we treat these patients. Now, to understand the treatment, you have to understand your target, and we know the target here is the BRAF mutation. It can occur in exon 11 or 15. Commonly is the exon 15 and the V600E. However, you should also know that there are other BRAF mutations like V600K and V600R, and then the uncommon ones. When you do a PCR, which is what is recommended, you will pick up only the ones you are screening with your probe. But having said that, now a lot of centers are doing this on NGS, and when you do NGS, you also pick up other mutations which are uncommon. And so the real implications of these mutations we still don't know. We are still learning. However, as long as there is a mutation, these drugs are worth a try. And that's what I'm trying to show you in this curve. And you say that when you see if you have V600, E, K, or R, they respond to therapies better as compared to non-V600 mutations. Now, there's some data to say that whether you have V600E or K mutations, you do have this combination still is effective. And this is a recommendation from the guidelines that you must do a PCR and NGS based on what is available at your place. Now, let's quickly review the data we have with this combination. So what I'm trying to do is I'll show you a 5-year analysis of a combined analysis of these two large randomized trials. And when I say combined, I mean that if you see the trials were different. One was COMBI-d, other one is COMBI-v. V stands for Vemurafenib, and D here stands for Dabrafenib. Now, uh, the control arm, one was Vemurafenib, one was Dabrafenib. When these trials were designed, the single agent BRAF inhibitors were the standard of care, and it was compared with the MEK inhibitor, Trametinib, in the other arm. So now, because the treatment arm is the same, Dabra plus Tremi, it makes sense to combine these two trials and analyze them together. That is what was presented about 2 years ago in ASCO, and I'll show you that data. Now, the kind of patients who go into the trial, they're extremely fit patients, right? Good performance status. However, they did have patients who had M1B and M1C, that is multi-system involvement. If you see, the number of patients who had a normal LDH was 65, and patients who had high LDH was about 30, the rest of the 45%. And only 11% had significantly high LDH, that is more than 2 times. Also, the number of sites involved, it's also a prognostic factor here in this disease. And less than 3 sites involved is a good feature, which is there in half these patients. Looking at the progression-free survival with this combination, if you see, the progression-free survival curve is quite encouraging as compared to what we used to have earlier with no treatment or with chemotherapy, with a 30% of patients having been progression-free at 3 years. This is in all comers. Now, when you look at 5-year overall survival, right? This again is at 2 years, it's 52%, and it drops, but not so much. And at 5 years, is about 1/3 of your patients are alive if in the trial when they had started on this Dabrafenib Trametinib therapy. So number of patients who are progression free is about 20% at 5 years, but number of patients who are alive, that means they must be on some other therapy, are it's about 34% at 5 years, which is pretty good for this disease. Now, when you talk about overall survival, you also need to ask yourself how many of these patients actually got an immunotherapy after progressing on the TKI, and that number based on this presentation was about 34%. So 34% is 1/3 of these patients did go on and receive immunotherapy, and the rest of them had other therapy like chemotherapy, and altogether 53% of these patients had some subsequent therapy. Now, what kind of responses do we see with Dabra plus Tremi? So if you see complete responses, again, complete response is something very good in this melanomas, which it does happen in about one out of 5. That's about 19 patients did have complete response. Partial response is more common. Half of those patients, 50% partial response, and the remaining stable disease. So if you see in terms of objective response, what you desire and what patients also look forward when they come for the first visit after starting treatment is as high as 68 to 70%, which just tells you that these are very active treatment options. Now, when the authors tried to look at the outcomes, the PFS and OS based on their LDH level, they found a striking difference. So if you had a patient who had less volume disease, normal LDH level, you see right compared to left, these two curves look totally different, right? And the PFS here at 5 years was 8% versus 25%. And when you look here, the overall survival was 16% versus 43%. So it did matter if your LDH was normal or less than normal, normal or in the normal range. Now, this is true even with other studies, and this is the COBRIM analysis where we are looking at the other molecules, the Cobimetinib and Vemurafenib trials. And this finding is consistent across all studies that LDH is a very important prognostic factor. The PFS, if you see, looking at LDH normal versus high, there is a stark difference. Now, is LDH a marker only for TKI? Is it true for immunotherapy also? Actually, if you look at the immunotherapy data, LDH is important even there too, where you have patients who have very high tumor volume, more than 2 times upper limit of normal. If you see the curve on your right hand side, very close to 70% of them are progressing at 3 months itself. And the number and the fraction of patients who derive any benefit from these drugs are very hardly less than 10 to 20%. So in patients who does this mean that in patients who have large volume disease, is immunotherapy not a good option? Maybe yes, because it's a general treatment. It doesn't have it doesn't act on a target. On the other hand, you have TKIs which produces high response rates, and they do act on a target. And the same holds true LDH levels based even in the Pembro trials. As you know, Pembro is approved in later lines in this disease. Now, other than LDH, you can also look at the number of sites, number of organ sites. So lung, liver, bone, brain, etc. So if you have a patient who have less than 3 organ sites, that though the outcomes, the PFS and OS is much better. And the 5-year OS seems to be 55%, which is half the patients alive at 5 years, which is phenomenal. It's something we all dream of. So now combining these two factors, LDH and also less than 3 or more than 3, you can actually divide this cohort into almost uh, uh, five five group, and you may say, and you will have a group which will do very well with TKIs, and you have a group who's not expected to do very well. Now, what about response? We all know responses, as I showed you, responses are pretty good and pretty fast. But do these responses last, and or how long do they last? So if you see, if your patient have had a complete response, that's real good news. The yellow curve, if you see the complete responders, I mean, they are progression free. Almost half of them are progression free at 5 years. So which is really good. Now, and people, if you have partial response, about 30%, about 28% are progression free.
So can you hear us? Ashish sir, uh, so we're not able to hear you. The head of faculty, Department of Medical Oncology at the Kovai Medical Center and Hospital. Without wasting any further time, I would request Bharath sir to please start with his presentation. Over to you, sir.
Uh, mm, Many thanks to Dr. Anita for this invite today, and many thanks to Novartis also for arranging a discussion on this very rare subset of lung cancer, but very important subset which we are seeing more and more. And this is very important because we are seeing not only just the numbers. These patients are going on from multiple lines of therapy, and we need to be aware of what next in the treatment of these patients. So it is about the therapeutic landscape for ALK positive lung cancers. The ALK positive lung cancers, if you look at all histology, it's around 3%, but we know that we are looking at mainly adenocarcinomas. And when we say all histologies, some of the histologies may not be IHC proven. And in adenocarcinoma itself, ALK may be around 7 to 8% positives in lung cancer adenocarcinomas. And for ALK inhibitors, we have evolved fairly rapidly from 2009 till now, from crizotinib to second generation ceritinib, alectinib, brigatinib, and ensartinib, and to third generation lorlatinib. So we have multiple agents in this arena. Now, the important thing that we must know is how to test for the ALK. Of course, we can do the FISH. FISH was the first test that was done, and FISH requires a lot of tissue. IHC is a fairly simple test, and if you validated it, many labs can do it easily. You could find it with RT-PCR, or now more and more we are moving towards NGS, which is a high throughput sequencing. Why are we moving more and more to NGS? We need definitely for the tissue diagnosis some amount of tissue, and we may use up some tissue for IHC to determine whether it's adenocarcinoma or squamous cell carcinoma or non-squamous non-small cell lung cancer. And then FISH requires more amount of tissue. But it is not just about testing for ALK-Fish. Now we know that in lung cancer, there are many mutations and there are at least 7 to 8 targetable mutations. There may be secondary mutations. So we have to look for all this. And when we have to look for all this, the NGS platform seems to be the best way for looking. So molecular profiling, especially to identify rare driver mutations, NGS seems to be the way forward. And whether we test with NGS or not, some form of testing for EGFR, ALK, ROS1, and PDL1 are mandatory testing as far as any treatment planning for non-small cell lung cancer is concerned. So we must have this test as a basic minimum. Now, in addition, of course, we have the BRAF, the HER2, now KRAS is coming into the picture, the MET mutations, MET exon indels. So many things are coming up. So we need a lot of tissue for all this. The NGS actually is able to massively parallel sequence large genomic regions. The one disadvantage is that an NGS may take up to 21 days, 14 to 21 days for us to get the report, whereas an IHC takes, ALK IHC, for example, takes much less time and is much cheaper. But NGS does look at the tissue in a more 360 degrees, and we can get more information on the tissue. What is the landscape as far as ALK-driven tumors are concerned? We had Ceritinib, Crizotinib was introduced in 2009, 2010, followed by Ceritinib, and then Ceritinib came into the first line in 2018, and then of course Alectinib also was closely on the heels. Alectinib came in second line, and then Alectinib moved up with the ALEX trial to the first line. And we had newer agents like Brigatinib and Lorlatinib, which have come in the last 1 year, which have now moved up from subsequent lines to first line also. So the initial trial, of course, all of us know the profile trial, which showed a progression-free survival of 10.9 months with crizotinib versus 7 months with chemotherapy. So this being the first trial, the standard arm here was chemotherapy. The overall response rate was 74% with crizotinib and a progression-free survival of 10.9 months. The ASCEND trial also randomized to chemotherapy showed a PFS, much better PFS of more than 1 year, nearly 16.6, 17 months versus 8.1 months. The PFS of the chemotherapy arm is nearly same in the profile and the ASCEND 4 trials. And a good large number of patients were actually alive at 18 months. That is the PFS, nearly 50% of patients were alive at 18 months in the ASCEND trial. And the overall, sorry, the slides are moving on their own. So with this, Ceritinib also was established as first-line therapy in the in metastatic ALK-positive non-small cell lung cancer. Compared to chemotherapy, there is a 34% reduction in the risk of progression or death with crizotinib, and it seems to be doing better in the Asian population. So the ASCEND trial, the Asian population subset, when we look at the 3 doses, the Ceritinib, the first dose was on a empty stomach, 750 milligram. The ASCEND trial had 3 doses, 450 milligram and 600 milligram after a low-fat meal. This was after confirming that the levels are higher. Therapeutic levels can be achieved with administration of Ceritinib after a low-fat meal. And so 2 doses, 450 and 600 in the fed state was compared. And with this comparison, the numbers are small. If you see, just 29 patients in the 450 and 750 fasted, and 19 patients in the 600 milligram fed state. But even with this small number of patients in the Asian cohort, one could see that there is a very good probability of event-free survival in the 450 fed state, which ultimately led to the approval of 450 milligrams of Ceritinib in the fed state, which also was associated with lower toxicities. So the conclusion was that results from the Asian subgroup shows there is high response and clinical efficacy And this clinical efficacy importantly was seen at 450 milligram per day with a low fat meal. And there was a numerically higher efficacy and definitely less GI toxicity compared to fasting 750 milligrams. Now we are all concerned about one aspect of non-small cell lung cancer in any driver mutation or non-driver mutation, that is the presence of brain metastasis. So approximately only 30% of patients have brain metastasis at diagnosis. That is 70% do not have brain mets. And what happens when we use Ceritinib in patients who have brain metastasis? Even in patients with brain metastasis, the median PFS was around 10.7 months compared to chemotherapy, which was 6.7 months. And without brain metastasis, the median PFS was much better at 26 months compared to 8.3 months. So there is definitely a signal of activity. There is definitely improvement in PFS, even in patients who have got brain metastasis when Ceritinib is used compared to chemotherapy. Now, the next thing that we all need to look at is the what happens after usage of first generation TKI. We know that brain is a sanctuary site, especially in non-small cell lung cancer. In later lines, the percentage of CNS metastasis usually increases and can go up as much as 50 to 70% in later lines of therapy. That is after first exposure to the first line of therapy. So what was the ascent for intracranial response? Intracranial response is something that again, but the ascent for Asian subset, the numbers are quite small, but there seems to be a good response in the intracranial response also for patients who are on Ceritinib compared to chemotherapy. So what about the safety profile? The drug, I think we've all used Ceritinib over the last 3 years, and we know that the safety profile, especially compared to chemotherapy, is good. The quality of life scores definitely is good. There, Ceritinib consistently has shown an improvement in quality of life in comparison with chemotherapy. Now, coming to the other agents in the group, the next important agent, of course, is alectinib. Now, the difference between the first two agents, crizotinib and Ceritinib, they were compared to chemotherapy. From alectinib, the comparison has been to the first generation TKI, ALK TKI, which is crizotinib. So alectinib, when compared to crizotinib in the first line, showed a very good median PFS of 25 months compared to 10 months. 10 months is what we saw in the comparison with chemotherapy also. The 10 months remains the same in this trial also, but nearly more than double the PFS was achieved when alectinib was used in first line compared to crizotinib. And what was the cumulative incidence of CNS progression? The CNS progression incidence with alectinib came down to around 10%, whereas it was nearly 40%, 41% when crizotinib was used. The other agents that have been used in the same setting, one is the ALTA trial, which evaluated brigatinib in first line. The investigator-initiated median progression-free survival was not reached in the brigatinib arm, and in the crizotinib arm, it was 9.2 months. So we get a sort of this 10 months with crizotinib, but the newer generation, including Ceritinib, alectinib, and brigatinib, are showing much longer median PFS. The 1-year OS probability of brigatinib was nearly 85%. In patients with brain metastasis also, brigatinib does show good CNS activity, and the hazard ratio for intracranial progression or death was definitely significantly lower with brigatinib also. So that also shows activity, intracranial activity. The most recent study, of course, was presented in ESMO, the CROWN study, which again evaluated lorlatinib. Now, like the ALEX study, in the first line, the comparator arm remained crizotinib, which is the first generation. Lorlatinib is a third generation agent. Lorlatinib was dosed as 100 milligram OD. The randomization was 1:1. Now, in the primary endpoint was progression-free survival. The primary endpoint was significant. At least the PFS was 12-month PFS rate was 78% with uh, lorlatinib, whereas just 39% with crizotinib. The hazard ratio was significant at 0.28. But we must remember that this study, at least to my latest reading, the overall survival for this trial is still pending. So the Crown study we do not, and of course the Alta, we don't have the mature overall survival for both these studies yet. So the what we usually get in patients without brain mets is around 10 to 11 months with crizotinib. And if it is ceritinib, we get around 26 months, and maybe with the alectinib, we get up to 34 months. In brain mets patients, we get quite dismal 7 months with crizotinib, a much better nearly 11 months with ceritinib, and a longer 28 months with alectinib, which has got the better CNS penetration. I'm sorry. Uh, what about the adverse events? So each of these drugs have slightly different adverse events. I will not at all touch upon ceritinib 750 because I think we've all given up on that dose. Visual disorders are higher with crizotinib. Um, with ceritinib, visual disorders are rarely seen. GI effects are there with ceritinib, but mainly with the 750 fasted dose. When we see use 450 milligram after low-fat diet, the GI side effects are fairly low. Fatigue is fairly low, and the LFTs grade 3, grade 4 are also present, but not very common in practice. Now, the NCCN, this NCCN is slightly older. The NCCN has currently updated, and they have included alectinib, lorlatinib, and brigatinib as the preferred first line. So there is an updation on this in the first line. So what are the key important take-home messages regarding ceritinib? In the ASCENT 4 trial, in ALK inhibitor naive patients, ceritinib shows improvement in PFS, and definitely there is an improved OS. The data is still not fully mature. There is a definite PFS benefit regardless of presence of brain metastasis, telling us that unlike crizotinib, ceritinib definitely has CNS penetration and some amount of CNS activity. Grade 3, 4 GI events are definitely manageable, especially in the lower dose in the postprandial setting. So efficacy and safety is definitely well established in our population, that is the uh, Asian patients. Now, superior efficacy in the first line, why should we use? We should put our first bet as the best bet because many patients may not go to second line. And brain mets are something that we have to think about in two ways. One is we have to think of patients who present with brain metastasis, so we need agents that penetrate the brain. Secondly, we also have to think of patients who have on treatment CNS progression. So patients who have the longest time on a drug without a CNS progression would definitely be, that agent would be the best choice. So the longest time without a CNS progression, that is something that we have to look at patients who do not have brain mets at baseline. And we need agents with rapid response. So what is the status looking like today? If we use drugs like ceritinib in the first line, we get nearly 26 months, that is nearly more than 2 years of progression-free survival in the first line, after which we can use other agents. Of course, this says lorlatinib. We could use the other agents also. I wanted to add a few slides which I could not. There are now many ALK mutations, and lorlatinib seems to be one of the drugs which is still, not lorlatinib, sorry, crizotinib seems to be one of the drugs which is still active against many of these mutations. So using crizotinib in a later line, once these mutations develop, would be a better choice rather than using crizotinib in the first line. And of course, we have other agents like lorlatinib, brigatinib also to be used in the first line. So is the voting thing ready from their end? If it's not, thank you very much.
Yes, yeah, thank you. Thank you, Dr. Bharath, for taking us through. Thank you so much. The nice background of your hospital behind you, it looks very posh. Thanks a lot, Bharath, for joining us. It was a good talk. Okay, and is Dr. Ashish ready with the presentation?
Uh, Madam, I've almost done. We can do the panel discussion.
You want me to go with the panel?
Yeah, we can go with the panel because I had almost done it. Only 1 or 2 slides were left.
Okay. Okay, just one. So we'll. Okay, just one. Just give me. Mm. Are all our panelists joined in, Kashish?
So now we have Dr. Tanka Johnson who has joined and Dr. Siddharth who has joined. Also Dr. Ashish and Dr. Bharath have also joined. Dr. Vinod and Dr. Ashwin will join us in some time, ma'am.
Okay. Mm. Okay, the ALK slides are there. I don't have the ALK tumor slides. Okay, just 1 minute. I'll just send it and we'll start off. Okay. Mm. Just 1 minute. Yeah. So very good evening to all of you who have joined in today evening for our discussion. Okay. So let's introduce our panelist for today's evening. Okay. I invite just 1 minute. Okay, so for our first talk will be on the case-based discussion because we heard about the ALK-driven tumors. So I invite Isha Jaffa, Dr. Chandramouleshwari, again Dr. Bharath Rangarajan and Dr. Ashish to continue, Dr. Sanjeev Agarwal and Dr. Fabi Sovan. Is all the panelists there with us?
Ma'am, only Dr. Bharath and Dr. Ashish have logged in. The rest will log in at 7:40, ma'am.
Okay, 7:40. So should we wait for them? What should we do? Because we have a lot of questions on them. Dr. Ashish said, without we wait for Dr. Ashish to start.
Go, please. Uh, I can discuss something on melanoma if there are any questions or.
Okay.
Are there any questions or anything on melanoma? Because we don't have a panel on melanoma, ma'am. We have a panel on lung.
We have the same panel talks for both.
Okay.
So let's start with the ALK tumors. Okay. Since yes, Ashish, you're going to speak after this now on the BRAF.
I finished that, ma'am. I started at 6:30 with that.
Yeah. So let's start off with the discussion. Okay, and let people join in, and as soon as somebody joins in, you let us know. Okay, we will inform them. Okay, just 1 minute. I'll share the screen for the ALK. Okay. Okay, so that's it. Warm welcome to everybody and a nice talk we heard. We have two panels back to back and the panelist is almost the same. And please inform us if anybody joins beyond this. So let's take this through an ALK-positive tumor. So elderly lady, adenocarcinoma, we had fluid from the cytology, bronchoscopy, and you can see the mass which is detected and multiple mets in the lung. And then how will you approach to a diagnosis? Any one of you, would you like to use the pleural fluid or would like to take a tissue biopsy and to proceed for the molecular testing? Dr. Bharath, we'll start with you. Dr. Bharath?
Bharath, sir, you'll have to unmute your mic, sir.
Sorry. I would as of now, I will say what I am doing, ma'am. In such a situation when there is a pleural fluid, what we are doing is we are getting a quick pleural fluid cytology. And whenever a cytology is being done, we are also sending an additional request for a cell block to be prepared on the cytology fluid. And when it is positive, we are able to get a diagnosis of malignancy within 24 hours. And many times the cell block processing within around 48 hours, we are also told that there is a good cell block with enough tumor tissue for doing additional testing. If that is the case, then we do not proceed further with biopsy in patients who have got, both the cytology positive and a good cell block with tumor tissue. But if it's not available, then we would proceed to go ahead with a bronchoscopy or a nebus biopsy or a CT guided biopsy, depending on the location of the lesion.
Okay. If Dr. Chandra Maulishwari is there and Dr. Tanga, ma'am, your opinion from like Dr. Bharath has provided with tissue, either tissue, a fluid with cell block, or you also have a two-cut biopsy. How will you proceed?
Hello, I'm Dr. Tanga here. Am I audible?
Yes, ma'am, we can hear you.
Yeah, whether it's a pleural fluid cell block or through-cut biopsy, first confirm the diagnosis whether it's a non-small cell carcinoma. Then, if it is non-small cell carcinoma, then you between squamous and adeno. So squamous and adeno with sometimes it is straightforward, otherwise you go ahead again with immunohistochemistry. And if it is adeno, whether it is primary or secondary. Okay, if it is primary adeno, then we think of molecular testing, and that is 74 years old, no head, no brain metastasis, then we go for other mutations like EGFR, ALK, ROS, we go ahead depending on already studied.
Dr. Chandra Maulishwari, please.
Yes, ma'am. Good evening, ma'am, and thanks for the invite. As Tanka ma'am rightly pointed out, yes, it could either be a cell block or a true-cut biopsy, ma'am. In cell block also we can have enough material which is available for us for testing. That is like in a cell block, only thing which we have to be careful of is that it could either be a mesothelial cell proliferation or a tumor. So that is the usual confusion which always we will have when we get a cell block for analysis if we have to commit towards malignancy. So IHC will definitely be required if in case it is a cell block which has been provided to us, after which after the confirmation of adenocarcinoma, as rightly pointed out by Tanka ma'am, we will definitely proceed with a mutational analysis, and partly the mutational analysis is done by immunohistochemistry and partly by RT-PCR in our center. So for IHC we take ALK and PD-L1 are done by IHC, and the remaining are being sent for, after taking the slides sections for ALK and PD-L1, we send the rest of the tissue for EGFR analysis, KRAS, EGFR and ROS analysis, ma'am.
Okay. And Dr. Vinod? Dr. Vinod is there?
No, ma'am, Dr. Vinod is not logged in.
Okay, not logged in.
Ma'am, we have Dr. Siddharth Bhatt.
Yeah, Dr. Siddharth. Dr. Siddharth?
So you'll have to unmute your mic. Dr. Isha has joined.
Okay, okay. Dr. Sanjeev Agarwal?
Not yet, ma'am. He's in another webinar.
Okay.
So one question I had was that even if it is a squamous cell carcinoma, I mean the biopsy can still go for molecular analysis. And a comment I would definitely like to make is that especially in lung, the biopsies are very tiny. So when it is cut and and if you go by FISH and EGFR, so these biopsies are usually cut into two separate labs to it. Instead of that, if you go for NGS, then the entire biopsy can be crushed in like one go. Separate out DNA, RNA, and then DNA goes for the mutation analysis, RNA goes for the fusions. So that way, the probability that you will come back with an answer is kind of higher rather than cutting the biopsy and sending it to cytology as well as to molecular.
Yes, Dr. Siddharth. Yes, that's I think that will be the future. Again, Dr. Suman Febi is there. Dr. Suman Febi?
Ma'am, she's not there.
Okay, then either Dr. Tanga and Dr. Chandra Maulishwari, you can take this what Dr. Siddharth has commented.
Ma'am, I want to add just one point here, because if we send the entire tissue for mutation analysis, we have two problems in this. PDL1, of course, we need an IHC, so we always have to take a section for PDL1 immunohistochemistry before the mutation analysis is being proceeded with. That is always by immunohistochemistry only. And ALK also, like by NGS, there are literature reviews which comment that it is either by FISH or by IHC, which is a reliable modality of testing for ALK rather than NGS as such, because NGS detects the mutations, but the fusions and the translocations and large deletions, which can also happen with ALK, is not detected preferably by an NGS. So that is one disadvantage of sending the tissue directly towards either a DNA or an RNA sequence.
So here I definitely want to intervene that fusions are, NGS clearly detects it. It's the mutations. So what we do is DNA and RNA we separate out, and fusions are detected by RNA analysis. But NGS definitely does it. Although I do agree with Thanga madam that it's always an ongoing problem that with the tiny amount of tissue,
Yes.
what
Yes.
should take priority. That's a never-ending discussion.
Okay, thank you. So let's see the ALK testing. Now we will concentrate ourselves for the today's discussion for ALK. So, so again, quick, I would like to hear from the panelists. What is your thought process about ALK testing and how do you do in your place?
Ma'am, in my place, it is by immunohistochemistry only, ma'am. And here again, there are split views. Like NCCN endorses ALK testing by immunohistochemistry, whereas CAP doesn't agree very much with IHC testing for ALK as such. So either by FISH or by IHC. And in case IHC turns out to be a positive for ALK, then we confirm it by FISH analysis is what we do in our center. Sanka ma'am's views, please.
We also by immunohistochemistry only. And if necessary, we go for FISH confirmation. Otherwise, it's only by immunohistochemistry so far. But of course, the previous speaker has already said all the fusions, all can be detected only by NGS. Immunohistochemistry is the basic one.
Okay, so that's what we heard. The IHC is there, and you can go for a molecular confirmation by FISH or NGS. Okay, and the again the NGS forms a next generation sequencing, and we know that it is in our country, it is always difficult, and it's very also difficult to say that run the NGS. Okay, Dr. Isha. Dr. Isha is there?
Ma'am, she has some login issues with her device.
Okay, so she will not be able to speak. Okay, now, wanted to know from her what would she have done. Now, as we have heard already, the available ALK TKIs and the FDA indications are we have many of them in line. That is alectinib, brigatinib, ceritinib, crizotinib, and the loratinib. Okay, again back to Dr. Bharath and Dr. Ashish also to take the question. Okay, we have so many ALK positives which are approved. So in an ALK positive tumor, what would be your first choice if you take this particular lady? Ashish and Dr. Bharath Rangarajan.
Yeah, hi, ma'am. Ashish here. So, we are actually very lucky to have so many options and to treat this disease. Now, I think the patients who, for them to benefit, it's important for them to get the benefit of most of these agents, if possible. So what comes to our mind is that in what sequence we should use this so that when we use the next drug, it should still be active. So we actually go by, we know that there's no doubt these third generation drugs are much more potent because they have been designed to overcome the deficiencies of the first and second generation ones. But we also know that this is almost like a chronic disease. We're talking about PFS and OS in terms of 3 years and 5 years. So what happens in the next 1 year or 2 year may not be that important as long as the patient goes on and takes all the available options. So therefore, in terms of sequencing, the first generation, I mean, the crizotinib, now we know that crizotinib was actually not developed to be an ALK inhibitor. It was actually developed against ROS. it did have activity against ALK, and that's how it got approved. But with terms of other options with like Ceritinib and Brigatinib, they seems to be much better. And we also know that once you use Ceritinib, subsequently your Alectinib is going to work, and after Alectinib your Lorlatinib is going to work. But what I don't know is if I use Alectinib upfront or Lorlatinib upfront, how my patients are going to behave after they progress. So with that in mind, I discuss these options, and also cost plays a major role, because there's no point starting a therapy and then your patient is unable to continue it after 6 months. So with all these things in mind, I think Ceritinib is my first option. And unless the patient really has large brain mets, and where I really want to have a drug which penetrates the brain really well, in that case I go with Alectinib or Lorlatinib.
Okay, thank you. That's what we heard about him, talking about that Ceritinib may be a very good option at this point of time. And as you see, category 1, Alectinib, Brigatinib, Ceritinib, all of them has been given approval in the first setting. And if you see the first line preferred therapy, again, Ceritinib is there, but then with Crizotinib, like how Dr. Ashish has mentioned, was approved, worked out for something now, but can be used in certain occasions. Okay, and so how do we improve the survival? And that's rightly said by our speaker, Dr. Bharath Rangarajan. And okay, a quick question to Dr. Bharath, back to you. Now, now the third generation and maybe the second generation, they have a greater CNS penetration. Okay, so if a patient, now you know the NCCN guideline says in a non-small cell lung cancer, a brain MRI is to be done if you have not, whether symptomatic or asymptomatic, an MRI brain is needed. If you do a PET, it gets covered. Now, 2 scenarios. A patient has brain mets, what would be your drug of choice if the patient is ALK positive, and that not no brain mets, what would be your drug?
In the first line, if the patient has brain metastasis, I would slightly prefer Alectinib if the patient can afford Alectinib. That would be my choice if there are brain metastasis. If there are no brain metastasis at presentation, then my choice would be between Ceritinib and Alectinib again. I, for one, will not, really choose one over the other. I do discuss with the patients, and I would prefer to go with whatever the patient can afford at that point of time, because we know that most of my patients without brain metastasis on first line are actually, and with brain metastasis are actually on Ceritinib. The reason is mainly the cost. But if a patient could afford, I do not mind starting even patients without brain metastasis on Alectinib in first line. But it would be between Alectinib and Ceritinib in the first line. Now the approval has come after the Crown and the ALTA data. Although the data for Crown OS and all is not mature, approval has come for both Lorlatinib and Brigatinib. But I have not used these agents in first line. So I still am sticking to Ceritinib and Alectinib in the first line.
Okay, thank you. Okay, anybody else wants to comment? And anybody?
Dr. Isha, are you able to unmute your mic, ma'am?
Dr. Isha. Okay, anybody else wants to take this question? And where do you place Lorlatinib? We do have, and third generation ALK inhibitor. Isha? Okay, or any of the panelists wants to add in before we move to the next slide. So these are the, by the different studies like Accent 4, Alex, Alta, and we heard that the Crown, what Dr. Bharath alluded on, and there's also another drug, Anticancer, which had EXALT-3. So they looked into the response rate, the CNS mets, and the progression-free survival. Okay, so and these are the different studies. And we have heard about these studies. We will not get into all of them. Looking into progression-free survival, the accent 4, where the Ceratinib was the drug and profile with crizotinib. And definitely, if you see the progression-free survival was 16.6 months compared to 10 months in the profile study with crizotinib. And so that again shows in Asian patient with the subgroup analysis, it's a very good option with ALK rearrangement. 34% reduction in the risk of progression and risk of death is seen. So these are head-to-head trials of the TKIs, that is the ALX with the alectinib, and with the ALTA with the brigatinib, okay, showing the overall response rate and this thing. Now, quickly, again, back to all the panelists, and already you have hinted on the cost. Okay, so what factors will drive you? Okay, once again to Ashish and Bharath. Okay, Ashish, you do work in a different scenario, different from what Dr. Bharath is working. So how do you manage your TKIs, ALK TKIs?
Yeah, so madam, as I initially mentioned, that it's important for the patient to stay on these drugs to derive maximum benefit. And even Ceratinib, even though the cost is the lowest amongst all TKI, many of my patients actually struggle after a year or so, and it's actually quite heartbreaking to see that their disease is responding so well, but they're struggling to stay on therapy. So therefore, cost Ceratinib wins hands down. And in terms of CNS activity, also I just want to highlight here that agree that the CNS penetration is much better with alectinib and lorlatinib. But however, many times where our tumors have been operated on or radiated on, the blood-brain barrier is not that intact, and we have seen responses even with Ceratinib in the brain and in treated patients. So just reflexly, just because there's a brain metastasis doesn't mean you jump onto these third-generation agents. You always, if you're desperate for a response and you don't want to take a chance, that's another issue. Like somebody has hemiplegia, a large tumor. But then if you think it's a small tumor and you can always give it for 3 to 4 months and repeat an MRI and confirm that Ceratinib is working in the brain, I do that most of the time. Patients' preferences, again, here it's the toxicity which comes in. And other than the cost, it's the toxicity. And most of these drugs are very well tolerated, especially with dose reductions if required. And Ceratinib has this added advantage that when you take it with food, your pharmacokinetics differ, and therefore many patients are actually just taking 300 milligram, not even 450 milligram, and they're doing well on that.
Again, Dr. Bharath, I think your choice will be again Ceratinib with CNS meds. Dr. Bharath? Dr. Bharath is there?
Bharath, sir, you'll have to unmute your mic, sir.
I'm sorry. If the patient has CNS meds at presentation, and the patient is able to bear the cost of alectinib, my choice in patients with brain mets is usually alectinib. Having said that, there are only few patients who are able to take the cost of alectinib. One point that Ashish made, it's not about starting the drug for the first 3 months. They have to stay on it long. And what I've seen with alectinib is that the patients really stay on it for a very, very, very long time. So some of my earliest patients are on alectinib are still on alectinib. So they will need to afford it for that much time. So that's a very, very small subset. But yes, my choice on patients with brain mets would usually be alectinib if they can afford. If they can't, it would be Ceratinib.
Okay. Yes, I think that yes, in a resource constrained country like ours, and like I do agree with you. And many in my medical college, believe me, many of the times I will not be able to do the ALK testing also. But though it is little cheaper, but then we do the test, we'll not be able to put them because we don't have any generics available at this point of time. Okay, there is a generic, but then I think there is certain litigation issue. So this is the only drug. So you're right. Less than, I would say, 2 to 3% if there are 100 ALK positive tumors does get a benefit. And so this discussion also brings to the point to the company to make it more available, such a good drug. And we had so much of data, and all of us are in favor of this drug. Okay. So let's move on to the other presentation for tonight. We couldn't get Dr. Ashwin is also with us. Dr. Ashwin?
Ashwin, sir, you'll have to unmute your mic, sir.
I would like to know from you, like you heard Dr. Ashish and Dr. Bharath talking about the drug. Now, what are the other things would you like to do? Radiation, okay. How do you go about it?
Sorry, ma'am. Now only I joined. I don't know what had happened. You just bring me
CNS
that.
next. I'll give you this thing, a patient with a CNS tumor, the lung primary non-small cell ALK-positive tumor. Okay, patient is having multiple CNS disease. Okay, the surgeon had said it is inoperable. We are taking your opinion. Dr. Bharath and Dr. Ashish has started the patient on Serotin. What is the role of radiation and how do you go about it?
We can do whole brain RT, madam. Or depends on the number of meds whether we can do SRS or SRT or whole brain RT or a combination of both these things. The hippocampal sparing.
Okay, now this is something I wanted to know. Initially, we used to talk about whole brain RT. Now, for all patients, do you do hippocampal sparing, or it is something which is coming up new, or what happens to that area?
No, madam. Usually, we do with subgranular zone. That is the main thing in the hippocampus, with which the neurocognitive function can be preserved. So we are trying to spare as much as possible in order to restore the neurocognitive function. So if the number of meds, depending on the number of meds and the area location of the meds, we can try to reduce the dose to that area so that patient will have a good quality of life.
Okay, and which are the patients who are eligible for radiosurgery or stereotactic radiotherapy? What is the size of the tumor?
Usually within around 3 centimeter will be ideal, for which we can give high dose to the patient.
High dose to the tumor. Okay, yeah. Fine. Okay, let's move on to the next part of the talk. Okay, so this is regarding the case of a melanoma. Now, this is a 43-year-old male, okay, in the forehead, the blackish pigmentation increasing in size, malignant melanoma, 3.5 centimeters, diagnosed ST2B NXMX. Okay, Dr. Isha, I think she's there with us. Can you help her to talk?
Ma'am, she's having some mic issues, but she's posting the comments on the chat.
Okay, we'll then take it later on. Any one of you now? Quick question to the pathologist and molecular oncologist. Any one of you can take now. Once you have a tissue for melanoma, okay, what are the markers apart from histopathology you do, and when do you run the NGS panel or to look into the BRAF? Pathologist, Dr. Tanga, Dr. Soman, Dr. Chandramouleshwari, Dr. Vinod, anybody?
The routine histopathology, standard histopathology is very, very important, starting with margin, then Clark's level, lymphovascular invasion, tumor infiltrating lymphocytes. Apart from the routine standard reporting of melanoma, the next one is you do PD-1. And of course, BRAF mutation is a must. How we do, it varies from center to center. If we want to in resource poor center, there also BRAF mutation is a must with RT-PCR. Otherwise, you can go for next generation sequencing. That's our approach.
Okay, and Dr. Chandramouleshwari, do you would like to run the entire NGS panel, because what are we looking at for a melanoma? Dr. Chandramouleshwari?
Dr. Chandramouleshwari, you'll have to unmute your mic, ma'am.
Okay. So, ma'am, at our center, we do not send the entire NGS panel.
You don't do it. And do you do the BRAF testing? Do you do the BRAF testing?
Yes, we do. We do the BRAF testing. It is not done by IASLC, ma'am. It is being done by RT-PCR in our center. We send it across for RT-PCR.
Okay, but then what is the standard procedure for doing the BRAF testing?
Testing routinely, initially with RT-PCR. Yeah, RT-PCR only.
Can you
And
please repeat the
and
we do it by RT-PCR.
600E.
Okay. Hmm.
So I would like to add just
Dr.
one
Siddharth.
comment that if we do sequencing here, the good part would be that in one go we would know whether it's a classical BRAF V600E or whether it's a variant of that, and accordingly the oncologist can predict what sort of response the patient might go through. Apart from that, ma'am, there are reports for mutations in NRAS and PTEN. So these both are, the oncogenes, and NRAS can go through both MAP kinase pathway as well as PIK3CA pathway. The PIK3CA pathway is the same where alpelisib or downstream everolimus works. So I don't know if there is any clinical trial for these kind of drugs on melanoma. Then there are a couple of tumor suppressor genes also, P14, P16, etc. Though nobody can, I mean, as of now, they can't be targeted, but they might have some consequence on the prognosis of the patient or the aggressiveness of the disease. So I think a good panel designed at NGS platform might be a good idea. Even if it's a small panel, it should do justice.
Okay, to pick up the BRAF mutation, other mutant forms, and the subsequent lines of therapy. Now,
Yes,
that
ma'am.
doctor, one more quickly, do you do the PDL also? If you have to choose two things, BRAF and PDL1, do you run it together? Because see, for the other things, we may not have the drugs ready.
PD-1 can be done by immunohistochemistry. But before choosing the molecular method, madam, the melanoma, depending upon what type of melanoma. If it is a hereditary melanoma type of melanoma, so many mutations are there. So in such scenario, you can go for an NGS. Otherwise, RT-PCR is enough. PD1 is done by immunohistochemistry. It's not that costly. BRAF RT-PCR.
Okay. Dr. Siddharth, your comments over here, because these are the two actionable targets, or we have drugs for that.
Yes, ma'am. As Dr. Thanka said, it is true that if you just want to target BRAF and its variants, so in that case, RT-PCR will have to be modified so that it can not just pick up BRAF V600E, but if there is any other variant also, it should. So then multiple multiplexing of RT-PCR tests would be needed. While sequencing, that helps because I mean, in one go, you will know if there is any other. But what I feel, ma'am, that typically so let's say if there is a small biopsy and whether PDL1 and the good part is that especially if there are tiny biopsies, NGS might make more sense because apart from BRAF, if there is any other target molecule, I mean target mutation that could be targeted by maybe an offline off-label therapy. So those kind of options become possible with NGS.
Yes,
Uh, that is what I feel it's an advantage.
yes. Dr. Ashish, Dr. Isha, as well as Dr. Bharath, multiple pulmonary mets treated with that. No, only surgery was done. Now comes with what will you do now?
Um, hello,
Yes, tell me, doctor.
hello.
Yeah, please.
So there is some noise. The in a situation where there is no prior therapy, with the availability of immunotherapy in first line, although I would ask for an NGS to look for any actionable mutations, including BRAF, maybe c-KIT mutation status, and other rarer mutations, I would still prefer to go with immunotherapy in the first line. Mainly because there is a little bit of difficulty in availability of other drugs, the targeted drugs.
Okay,
Sir,
yes.
I have a question here, a very
Yeah,
naive question that because is there has there been any trial where let's say if the patient is BRAF V600E positive, that both immuno and targeted therapy given simultaneously? I'm asking, I'm not a clinical person, so I'm just curious why both are not given, because both of them are very different pathways.
Dr. Ashish,
Dr. Ashish here, I can take that.
yeah.
Yeah, so that's a good thought. I mean, and then such trials are actually ongoing and they've completed recruitment. As I showed in my talk, that till now there have been no head-on comparison between the two, and now you're talking about combination. Now the thing is, in terms of responses, these agents do produce good response. The TKIs almost to the tune of 70%. Now adding IO, will it improve overall survival is the question, and because now we are looking at overall survival, it is going to take a long time for us to get those results. So at least the next 4 or 5 years is what my guess is. I think Isha can talk now. She's not spoken.
Thank you.
Okay, okay, that's fine. And so that's what we are looking into. The NGS, we heard the V600 is the mutation detection, hotspot mutation detection. And if it is positive, now again, Dr. Bharath Rangarajan, okay,
Yes,
now
ma'am.
what would be your preferred? See, if you see in an unresectable metastatic disease, okay, so many approvals are there. Category 1, nivolumab, pembrolizumab, all category 1 combination targeted. If BRAF activating mutations is there, Dabrafenib, you have Bemurafenib, and I think the last one is not available. I think, so what will be your choice? Everything is category 1.
Ma'am, again, there is a lot of availability issue. Basically, we don't see melanomas very often. I see a maximum of 6 to 8 melanomas in a year. So it's not a very common disease in my practice. That is the first caveat. And the last time I had a melanoma with a BRAF mutation, that was around a year back. And at that point of time, none of the BRAF mutation active agents were available, and we put the patient on nivolumab, and the patient has gone into a CR and had to stop because of toxicity. But as of now, most of my patients are on single agent nivolumab, irrespective of their mutation status. And there is data that, the drug actually works even if there is a mutation status. With the availability of drugs coming into the market, we may be thinking of the BRAF targeted agents. As of now, it's immunotherapy. Usually nivolumab. Again, IPI is not available. We can import it. The cost is very high. The doses for melanoma is also quite high. So it's just nivolumab for me now, ma'am, or pembrolizumab.
See, nivolumab with ipilimumab has shown better efficacy. Why not pembrolizumab? Pembrolizumab is approved as monotherapy.
Nivolumab also is approved as monotherapy, ma'am.
It's also approved as monotherapy.
But IP, we have tried to source IP from abroad. It's pretty expensive. That is one of the reasons.
Yeah, Dr. Ashish. Okay, so we have finished your talk.
Yeah, so I agree with Dr. Bharath, but I think for the last few months, both the Dabrafenib and Trametinib is available from Novartis. Cost is still higher; it's higher than immunotherapy cost. However, that option is available. Even EP now, I think they don't have a PAP, but it's commercially available for last few months in India. So so again here also sequencing becomes important, and but in terms of efficacy of these agents, I'm a bit more confident of using a targeted therapy when I know there is a target and when I know the response rates are high, and so especially when the disease volume is a bit high, and when I'm desperate for a response, I would probably go for a TKI. When the disease volume is low and then I want to see whether immuno is working or not, then maybe in that patient, immuno may be my preferred option.
Yeah, provided the mutation.
If I can add one thing about what Ashish said, I have to agree about one thing. Over time, at least on a personal level, I have been slowly getting disillusioned with immunotherapy in many settings. Whenever a target is available, I totally agree with Ashish. I don't have any experience with BRAF mutated melanomas on BRAF targeted therapies. Personal experience is zero. But if there is a target, I totally agree. I always prefer the target to immuno, because immuno sometimes, at least in my hands, is not as great as the people seem to say just maybe it's just my luck, but I don't get that sort of great responses.
Okay, thank you. And anybody, and Dr. Ashwin. Dr. Ashwin is there?
Ashan, sir, you'll have to unmute your mic. Sir.
Yes, ma'am. Available.
Ashwin, quick question. We are talking about immunotherapy. Okay, so the role of radiation in immunotherapy, abscopal effect.
Maybe hypofractionated radiotherapy can be tried, madam.
Do you think the primary drug is an immunotherapy and there is a area which needs to be radiated? So how is your thought process?
Sorry, ma'am, I didn't get you.
Radiation and immunotherapy.
Radiation, the trials have shown that immunotherapy has shown good results with the overall survival when compared to radiation. So radiation as of now is reserved only for palliative setting or where you cannot administer any other treatment.
Okay, radiation and immunotherapy together, has the results being little much better?
Maybe, madam, I'm not very sure about it. Combination of those two.
Yeah, whether we can. So what you said is correct. There are some data coming up saying that with the radiation and the combining, making use of the abscopal effect, the results are much better. I think let's take some of the questions from the chat box. That's what they this she said. I think Dr. Isha has posted. Dr. Sanjeev has joined in. Dr. Sanjeev Agarwal is there. Dr. Sanjeev is there. Okay, Dr. Isha, she has posted one question. If BRAF positive and we need an early response, then only BRAF inhibitor combo with MEK to be given. Okay, again, quickly, again, open to the discussion to Dr. Ashish and Dr. Bharath. Dr. Isha has said, if you need an early response, is there any data that an early response, these oral BRAF inhibitors combination with the MEK inhibitors act faster?
Yeah, so there is no data on the timing of response. However, I showed you complete response in 20% and partial response in about close to 50%. So 50 plus 20, 70% patients do have response. And patients who respond, they'd have much better progression-free survival and overall survival. As opposed to the single agent response rate with nivolumab or pembrolizumab, I don't think it's that high. So it's basically, but then if you have a response with immuno, those responses probably will last longer than the responses with TKI.
Okay, another question he has posted, because remember the case that we discussed was initially in an adjuvant setting, how you do. Any role of adjuvant BRAF inhibitors and adjuvant immunotherapy in melanoma? Dr. Bharath?
Adjuvant, to my knowledge, there is no mature or trial data, but I again may be mistaken. I think Ashish would be the person, because I have really not come across. I know there is adjuvant immunotherapy data, but I'm not sure about adjuvant BRAF inhibition in melanoma. Dr. Ashish would be a better person to answer that.
Yeah. So just to add to Dr. Bharath, I think there is data that adjuvant TKIs do improve progression-free survival and overall survival in node-positive melanomas. But however, again, in the same space as Dr. Bharath is saying, immunotherapy also improves overall survival and it's approved. So for most patients, there again, it's adjuvant. You don't have a disease and then you have nothing to therapies. But then we do have trials. These trials came before the IO trials came. The adjuvant therapies is also improving progression-free survival and overall survival.
Yes, so there is what Isha was pointing out. Yes, there is some data to there, some role of being a very resistant tumor there's an emerging role of using of adjuvant drugs in this setting. Now, any role of adjuvant immunotherapy? And any role of using IO and BRAF inhibitors together? Combo, she has asked the question. Anybody please, combination of the two therapy, do we have data or some emerging trials are there?
Yes, ma'am. So the combination we would not use now. wait for the trials to come out, especially the toxicity and efficacy. And on the other hand, adjuvant immunotherapy, yes, for node positives, for patients who have node positive disease, predominantly, especially with like microscopic nodal positive disease, they tend to benefit with these agents used in
Adjuvant scenario, yes.
situation.
Okay, Dr. Siddharth, you want to add any major points? Dr. Ashwin, few comments from you. I think we have done with all the questions.
No, ma'am, nothing more from my side.
Okay, Dr. Ashwin, melanoma and radiation, ALK positive tumors and radiation.
They've shown that it is beneficial in a number of nodes, maybe lymph nodes before and more than 3 centimeter, and extracapsular extension in the case of relapse, and hypofractionated RT can be tried.
Yes, okay, thank you. And if comments from the pathology side regarding any comments on the ALK positive tumors and the BRAF melanomas? Dr. Chandramouleshwari? Yes, please.
Am I audible, ma'am?
Yeah, please talk.
Hello.
Hmm.
Okay. So as regards to ALK positive tumors and with regards to IHC, there is one point which I wanted to stress upon. That is, there is a specific antibody. Even in immunohistochemistry, just the manual methodology will not suffice as the approved method. So it is only the D5F3 is the particular antibody, and that also has to be used in the Ventana platform for it to be reliable as a like if we want to consider ALK positivity by immunohistochemistry, this is the methodology which should ideally be adopted. So the specific antibody, and that also has to be used on Ventana platform, is one thing which I wanted to highlight. And with regards to melanoma, of course, we did talk about BRAF and PD-L1 and all those things. But I just wanted to bring in something which we happened to come across very interesting finding. That is, of course, as being periodically highlighted in all meetings, clinical impression and the clinical diagnosis in the previous history of the patient becomes very, very important. We happen to have recently a case of lung cancer biopsy from, it was given, the history was given to us as CA lung. The biopsy was done, it showed pigmented cells. And we were actually breaking our heads thinking of what it could be and all those things. Pigmented lesion, pigmented malignant lesion. Of course, melanoma was one of the consideration, but melanoma being extremely rare in the lung, we were actually breaking our heads, and then went back to the clinical history and happened to find out that 10 years back, the patient has had an amputation of the great toe, right side. So for melanoma, so clinical history and the discussion between the clinician and the pathologist becomes very, very imperative. Of course, it may not be the right time for me to highlight because we are all talking about the molecular genetics and all those stuff. But nevertheless, this I think is very, very important. The discussion has to be highlighted, and then the diagnosis may followed by molecular.
Yes, thank you very much. And we heard, is Dr. Sanjeev there? Just to have his
ma'am, he's logged out, ma'am.
Oh, okay, fine. So that's it, Kashish. I think I thank all the panelists, speakers, moderator. I thank Kavina Creation, Novartis, as well as Freedom from Cancer for bringing us together on two little different topics clubbed together. And I think that gives us an insight how to tackle these tumors. But as we know, the cost is very high. Again, a request to the company, and Novartis is doing a great job with the PAP program, but we need more PAP program from you so that I can hand it over to so many people who really need it, because the data is encouraging. Thank you, everybody. Thank you. Stay safe. Stay connected. We'll meet again. Thank you.
Thank you.
Thank you, ma'am.
Thank you.
Thank you, ma'am.